Hello, everyone, and welcome to the May issue of DermSurgery Digest. I am Michael Renzi with Lexington Clinic Dermatology, co-host of the podcast. This month, we are continuing with our updated format, which will separate the surgical oncology and reconstruction portion of the Dermatologic Surgery Journal into two 30-minute episodes. This episode, which we are calling Spotlight, will feature in-depth summaries and discussion on a few articles chosen by the feature editors. The second episode, Rapid Clinical Pearls, will cover the remainder of the journal, with the editors briefly covering clinical application of the data from each article. Our goal with this change is to make the content more digestible with a focus on clinical application and enhancing patient care. Our feature editors for May are Yesul Kim with Fairfield Dermatology, who will be providing the article summaries, and Divya Srivastava, Professor and the Director of Mohs Surgery and Dermatologic Oncology at UT Southwestern Medical Center, who will be providing the expert commentary. Thank you for listening. We hope you enjoy this new format, and as always, have a happy surgery day.
Welcome to the DermSurgery Digest podcast. My name is Yesul Kim, and I am a Mohs surgeon practicing in Connecticut. This month's featured expert is Dr. Divya Srivastava, who is a professor and director of Mohs Surgery and Dermatologic Oncology at UT Southwestern. We're so grateful to have you on our podcast today.
Thanks so much for having me, and thank you, Dr. Kim and Dr. Lawrence, for including me in this podcast.
This episode will highlight a few surgical oncology and reconstruction articles from the May issue of Dermatologic Surgery. And the first article that we will review is The Utilization of Mohs Micrographic Surgery for Benign Adnexal Tumors of the Skin, a systematic review by first author Drake Carter and senior author Stanislav Tokajev. As we all know, although benign adnexal tumors of the skin, such as trichoblastomas, desmoplastic trichoepitheliomas, hydradenomas, chondroid syringomas, and etc. are benign, there are cases of malignant transformation necessitating complete removal. The authors performed a systematic review summarizing clinical indications and outcomes of benign adnexal tumors of the skin treated by Mohs. They found that although most benign adnexal tumors of the skin are not currently recommended for treatment with Mohs under the most up-to-date appropriate use criteria, there are certain clinical scenarios such as large size, aggressive behavior, recurrence after prior excision, and cosmetically sensitive location that may justify the use of Mohs when treating these tumors. All identified cases of these benign adnexal tumors of the skin were treated with Mohs, demonstrated a high cure rate with only one recurrence. So what is your experience with these benign adnexal tumors located on the face? Do you typically do Mohs or standard excisions?
So for desmoplastic trichoepitheliomas, I do recommend doing Mohs surgery for this. Typically, these patients have had, it's typically young women that I see, and they've had lesions shaved off. Maybe recommendation was to observe it, but now it's coming back. So we know that we need to do a more definitive treatment. And with Mohs, of course, we know that's going to be tissue-sparing surgery, and that these are in cosmetically sensitive areas. With Mohs surgery, the Mohs AUC does have a mention of desmoplastic trichoep in there, and sometimes we do have to submit a prior authorization to insurance, but we've been fortunate that we've had success to get that covered. If there is like a clinical lesion still there when I see the patient in consultation, I'll usually recommend let's just do like a deeper shave biopsy here and make sure that there is no basal cell. And we have had some instances where the pathologist says, you know what, I actually think this is a basal cell. So I think that if there's something clinical still there when you see the patient, it's worth getting more tissue sample to see, is this desmoplastic trichoep or is this a basal cell? The other type of adnexal tumor that I have treated with Mohs surgery is a proliferating tricholemal tumor. And I think there's a lot of information that really shows that this is on a spectrum with squamous cell carcinoma. And the ones that I have treated are ones that were excised because initially it was thought that this was just like a pilar cyst, and then it recurred, and then maybe it recurred again, and then it was diagnosed as a proliferating tricholemal tumor. So I think that those, it's worthwhile to do Mohs for those. But for the other ones, I typically wide local excision if necessary. But sometimes after the biopsy, these don't recur, and I think they can be clinically monitored. But again, shared decision-making with the patient.
Mm-hmm. And do you, logistically speaking, do you bill it as Mohs or excisions with frozen sections if you don't get prior authorization?
For if I'm doing Mohs surgery, I'll bill for Mohs surgery. And I typically it's not recommended to bill for excision and frozen sections. If you're doing the Mohs technique, it really you should be doing bread loaf sections for that.
Sounds good. All righty. The next article we'll be featuring is Interrater and Intrarater Reliability of Mohs Surgeons in the Assessment of MART1 Frozen Section Margins for Melanoma by first author Caleb Freeman and senior author Justin Leitenberger. This study evaluated interrater and intrarater reliability of determining margin status with on-phos frozen sections with MART1 immunohistochemistry among fellowship-trained members of the American College of Mohs Surgery. The authors selected 20 cases of biopsy-proven MIS or PT1A melanomas that were treated with Mohs during a 3-month period. And they selected a single slide from one of the stages during the case immunostained with MART1. 8 were positive, 8 were negative, and 4 indeterminate slides were selected. Surgeons were asked to assess the same set of 20 slides twice with 6 weeks between each evaluation. And the study found that the Interrater agreement was 84.1% for the first assessment and 87.5% for the second assessment. And the average intrarater percent agreement was 95%. The studies show that there is substantial interrater and nearly perfect intrarater agreement identified among surgeons assessing melanoma margins during Mohs cases, and interestingly also found that rater accuracy appeared to be independent of experience level. So, as one of the authors and participants in this study, can you tell our listeners about your experience in this study?
Yeah, I thought that Caleb and Justin just did a fantastic job putting this study together and bringing together a wide range of Mohs surgeons who are more experienced, who learned this in fellowship versus people who are newer, maybe learned it outside of fellowship, to really show that, one, you can learn this in fellowship, but you don't have to. You can also pick up this skill later. And I think showing the the fact that you can be 0 to 5 years out versus more experience and you can still have high concordance is great. But I thought they picked great sample selections. It wasn't like this is obvious melanoma and this is obviously not melanoma. So I do think that it was a challenging slide set that really mimicked the types of cases you're going to see on a day-to-day basis. So I thought that was, they had well-chosen cases, really beautifully designed. I say to my fellows, every time we're looking at a melanoma with someone who has just severe sun damage, thank God that we have the rest of the, clinical pathologic correlation we can make. If we had to just look at this individual slide, it might be difficult. And it still is difficult sometimes, but it might be more difficult if we didn't have the rest of the clinical context. And I think that's one hard thing about just looking at a plain slide, but not necessarily seeing, having the patient in front of you and really like looking at all of their skin. And also, of course, we're used to looking at slides under the microscope, and this was looking at digital slides, which I think most surgeons aren't as used to. So that added just an element of, a little bit of a different feel to it. But I thought it was such a beautifully done study. And
Yeah, I think
expecting those findings. Yeah, I think I was surprised probably to see that there is such good high intrarater, because especially with those cases that are a little trickier, like I said, if you're not looking at that patient in front of you, sometimes you might be like that, that might be a little bit more borderline. So I thought that was an interesting finding.
yeah. And the study found that like the positive slides that had consensus tended to have that clear delineation between normal epidermis and then the increased melanocyte density. So during my Mohs fellowship for melanomas, we always had a positive control, which was a debulk, and then a negative control, which was a biopsy from like the contralateral skin on the like with similar levels of sun exposure. Do you also employ these controls during your Mohs for melanomas?
So for our positive and negative control, we actually used tissue from a patient who has non-melanoma skin cancer just to completely remove all variables so that the MART1, the stain with the MART1 and without the MART1 we've removed all other patient variables. And so that's sort of our positive and negative control just for the stain. Then when I do my Mohs technique, I take a thin strip through the central portion of the tumor for my frozen section processing. And that gives me an idea, that's stained with MART1, and that gives me an idea of what their tumor looks like. And then I also take, when I take that, I take the clinical margin plus, maybe 2 millimeters, because then my surgical margin is 5 millimeters. So I can usually see, okay, this was the melanoma, and then I see a little bit of that trailing edge. And so that kind of gives you an idea of like, okay, this is starting to trail off, or sometimes it's not. And we know we're going to have a lot of subclinical spread. So that's sort of our positive control. I typically don't do a contralateral biopsy. I know it's reported in the literature. I think there's some people who do it. There's a lot of people who don't do it. And I find that just having the patients, their 5 millimeter margin, you're going to see areas of increased density and areas of less density. And I think our goal is really to say within this patient's normal background, what is increased density and what is not.
Mm-hmm. Sounds good. All right, and the final article that we'll be featuring is a delayed full thickness skin graft after skin cancer resection, systematic review by first author Kishan Shah and senior author David Song. Reconstruction with full thickness skin graft can be performed immediately after skin cancer removal or in a delayed fashion. And there are some studies that show that impact of delayed full thickness skin graft after skin cancer removal, only a few of them. So the authors performed a systematic review to characterize indications, technique, and efficacy of delayed full thickness skin grafts after Mohs or wide local excision for skin cancers. They found 24 studies of 665 patients who underwent delayed full thickness skin grafts, and the most common site was the nose. The most common reported reasons were to promote formation of granulation tissue and to obtain a more definitive histopathological examination of the margins. The graft success was high with a mean of 89.6%, and the review found that the optimal time to delay was about 2 to 3 weeks. Grafts placed on the central face had lower success than lateral, upper face, and upper extremity. Outcomes were found to be overall favorable, and patients were satisfied with their results. So delayed full thickness skin graft seems to be a valid method of reconstruction after skin cancer removal, especially when there's inadequate vascular supply in the wound bed, or maybe a granulated wound would improve the 3D structure or the contour of the wound. Do you perform delayed full thickness skin grafts?
Yes, this has become a very important tool in my armamentarium for reconstructive surgery at this point. I do think that you can get, especially I'll use it for like the ala or the nasal tip, scalp, the ear, if there's like exposed cartilage or exposed bone. If I want to, get that contour filled in, I'm like, we're going to let this heal in naturally for 3 weeks. And I explain because we need to fill up that volume, and then we'll come back and do a skin graft. So I think that I use it in those cases where I'm like, this would be great for a graft, but we just need a little bit more volume. And I also find that sometimes patients, they see this defect and you're like, we could do a flap here, we could do a forehead flap, we could do a delayed graft, or we could do a cheek to nose. You offer them all these things and they're just like, oh, I just don't know what I want to do. And sometimes I say, you know what? We can take a pause. Let's let this heal for 2 to 3 weeks and we'll see how you do. And then we'll come back. We can always, if you were like, oh, I wish I did the flap, we can always go back and do that flap. But it buys the patient a little bit of time to kind of like mentally prepare and think about what they want to do. It buys us a little bit of time to say, okay, let's see how they heal. And a lot of times I will say, especially on the nose, especially on the ALS, sometimes patients come in and they're like, wow, I have healed so well. And we'll just do some light debridement to just make sure they're continuing to heal up and not reepithelializing too early. And they get great results just with second intention. And so I always say, I'm always going to offer you the graft. I'm always going to say, hey, if you didn't like that, you don't like the way that scar looked, we can always go back and do that skin flap. But once we've committed to doing a flap on the nose, we've kind of committed to it, and you can't change your mind and later say, oh, I wish I did it this, I say simpler way.
Yeah, I agree. I think getting the patient involved, and also just sometimes they just do so well with the healing without, like, less is more sometimes.
I'm always shocked at how well they do.
Yeah. How do you manage your wound when it's granulating in the postoperative period? Do you do like a bolster dressing or just non-adherent dressing? Do you use antibiotics topically or orally?
So typically, they go home with a pressure dressing for 2 days. I say, take it off in 2 days, go ahead and get in the shower, clean it with soap and water, fill it up with Vaseline. And I clarify, I don't want you to let this dry out or get a scab, because then you're going to reepithelialize early, and that's going to leave you with the divot. And the whole point of the next 2 to 3 weeks is to heal up. And I really emphasize that, like, moist environment, so that we can heal up to give you that good contour. And I say, I really emphasize Vaseline, don't be dry. And then typically I don't like sew on a bolster, and just they can leave it open to air, honestly, if they fill it up with Vaseline. And I recommend, at night when you're sleeping, to keep your sheets and pillowcases clean, you go ahead and cover it with, Telfa and a band, and, Telfa and tape. Typically don't use topical antibiotics almost ever. And typically don't do oral antibiotics either. I'll use them in a case of if we go back and do the delayed graft, then I might put them on the antibiotics, especially if we're working on the nose or the ear.
Mm-hmm. And there's such a variety of ways of performing a full thickness skin graft, and I love to hear everyone's like different perspectives and techniques on their full thickness skin grafts. Can you tell me a little bit more about how you typically perform full thickness skin graft? What's your typical donor site, for instance?
So especially if I'm working, typically I'm doing these grafts on the nose. I feel like I graft the nose a lot, or
Yeah.
the ear, and I'll use the preauricular skin. I know there's a lot of excitement now about using the nasolabial fold also, but I really like that area of the preauricular skin. Everyone's got like a little extra skin there, the lines there. So they also wrap their head around the fact that they're going to just, hide that scar in that preauricular crease. And I
Mhm.
like to I like to circle my defect with a marker, press a
Mhm.
Telfa pad onto that, circle that, and then press that onto my donor site. And I like to actually harvest my graft as the circle, as opposed to cutting out that ellipse and then stitching and trimming as I go. I like to just like cut it out, and I bevel my edges for the graft harvesting, because then my Mohs defect also has a little bevel there. And I feel like that just sits in really nicely. And then I like to use 5-0 fast gut and, as I think most people do, stitch it in, ship to shore, kind of sort of insetting that graft in with each stitch. If it's a little bit larger, I do some basting sutures, and I'll kind of
Mhm.
checkerboard that if it's a larger graft. But if it's small, maybe just one basting suture. I used to fenestrate these smaller grafts more, but now for the smaller ones, I've moved away from fenestration. So I feel like they'll come back and just have like a little bit more of that, like, you know, residual purple discoloration that lasts for a while. That's bothersome. They're like, the graft took beautifully, but I've got this like area of post-inflammatory, violaceous or erythema discoloration.
Mhm. And do you bolster typically?
If it's a larger graft, I'll bolster, but typically for these like centimeter or two, 1.5, 1.5 centimeter diameter grafts in the nose, I don't bolster anymore. One thing
Mhm.
I will do if we're working, especially on the ALA, is I will we'll put a pressure dressing on top, but I'll also take a cotton ball wrapped with Xeroform gauze and put
Mhm.
that into the nostril, so they're kind of getting pressure from the inside of the nostril and the outside of the nostril.
Okay, that sounds good. And when does the patient usually return?
And so we usually see them, if we're doing a graph, usually see them back in 7 days, 10, I can give them up to 10 if they're, traveling, etc. But I
Mhm.
like to see them in 7 days. I like to see them back again in 3 weeks to just make sure things are continuing to move forward. And then maybe again at like the 6 to 8 week mark. And some of my patients are coming from far away, so we're a little bit more relaxed on that timeline. And sometimes it depends on how you feel like the patient needs, how often you feel like they need to come back based on their anxiety level. And some patients just want to see you a little bit more, and I think that's fine. You just want to reassure that you're working alongside them to get them the best scar possible. And some patients are like, I've done this many times, I'm good, I'll let you know if I have an issue. So I think again, it's a lot of it's that shared decision making.
Mhm. Well, thank you so much, Dr. Srivastava, for sharing your experience and all of your insight. For our listeners, you can listen to our additional commentary on the remaining articles on the May issue of the journal on the same podcast platform you're currently listening on, or visit us at asds.net/DermSurgery-Digest for additional journal podcast content.
Thank you for listening to DermSurgery Digest, the official podcast of the Dermatologic Surgery Journal. To access these featured articles, author videos, and much more, visit journals.lww.com/dermatologic surgery. To learn more about the American Society for Dermatologic Surgery, visit asds.net.